All right, good afternoon, everybody. My name's Susan McKenzie. I'm the CEO of the Emergency Services Foundation. Somebody just said to me, I need some groovy elevator music while you're waiting to come on. Sorry, that's beyond my technical capability. In fact, we've had a few stressful moments here because some things haven't been working that well. So we're going to keep all fingers and toes crossed. So I'd like to welcome everybody today and start by saying that we acknowledge the traditional owners of the many lands that we're meeting today. People are joining us from certainly all over Victoria and places in Australia. Pay our respects to elders past, present and emerging. I would, as I said, I want to welcome you today. The Emergency Services Foundation is a Victorian organisation that exists to improve the mental health and wellbeing of the sector in Victoria. The idea of doing this program is that one of our strategic areas is to bring people together. To do that, we really want to connect people, harness and grow the collective wisdom across the sector. And we thought when we were planning this, what better way of doing this than speaking to the London Ambulance Service, never dreaming that Melbourne would be in the position it is today. It had its highest number of COVID cases here, an incredibly busy day. So I want to start by saying thank you to the people at London Ambulance Service for getting up very early in the morning. It's now 6:45 in the morning over there, and for just responding to my request to us. We really appreciate this opportunity to learn from you, and to say a huge thank you to Philippa Keir from the communications team for helping put this all together. We were to have an Australian paramedic talking to us this morning, but he is apparently sick, so let's hope it's not COVID. He's very disappointed that he can't be with us. Nevertheless, we've got a paramedic to speak to a little bit later. So can I just say to you, if you have a question that you would like to ask throughout, if you'd like to click on the Q&A box down the bottom and put your question in there, Justin and I will keep track of that and try and bring those questions to you. But we're going to start today by speaking to Kevin Bate, and Kevin may be familiar to some of you. He's been with London Ambulance Service since 2015. He started off with the Kent Ambulance Service for 15 years before coming to Australia, where he worked in Tasmania and in South Australia. So he was here for 8 years, so he's fairly familiar with us. He went back to the London Ambulance, and he's now operational lead for the north east sector of London, which has the financial districts and some of the most diverse boroughs of London. So he is in a role now where he is Assistant Director of Operations of the London Ambulance Service. So what better person to give us some insight into what's been happening over there and the lessons that they have learned in their experience. So Kevin, if you'd like to unmute yourself, we'll turn over to you.
Good afternoon. Firstly, thank you for the opportunity of joining. So as Susan said, my name's Kevin Bate, and I've been with LAS since 2015. In roughly on the from
Kevin, you're on mute again. I'll unmute you. Sorry. There you go.
Sorry. So as Susan said, my name is Kevin Bate. I've worked under the Ambulance Service since 2015. From roughly the end of January this year, the UK saw its first coronavirus cases, and as we know at the time, it was called Wuhan, named after the area of China that the cases originated from. And by early February, London actually started to experience its first COVID confirmed cases. From a context point of view, at the peak of the activity in London, we were receiving roughly 11,000 calls a day from patients. The reality of that is that, to put that into normal context, LAS normally would, on a busy day, would receive about 6,000 to 7,000 calls a day. So our activity almost doubled at the peak of the activity. And we had some significant pressures faced on us, not just as an ambulance service, but as a health system. And I've got to be honest and say, at the peak of the event, we did struggle to cope, and we had to make some very quick and dynamic changes to how we were triaging calls, how we were responding to calls, because the calls just absolutely outstripped demand at certain times of the day during the peak activity periods. At the worst of the coronavirus system, we would have up to 800 calls waiting to dispatch ambulances to, with no vehicles available to send, purely because of the amount of calls that were in our system. And that's, again, to put that into context, some of the work that we did meant that we doubled our actual operational capacity, and yet that still wasn't sufficient to cope. Interestingly enough as well, though, normal ambulance activity reduced. So all the actual activity we've received at the peak of COVID was coronavirus related. The downside for us as a service delivery provider as well was that, because of the requirements for cleaning of the vehicles after each coronavirus case, it meant that we would, at times when we had over 200 vehicles waiting to be cleaned, they couldn't be crewed. And these would having to go through specific decontamination processes by dedicated, specially trained teams of vehicle preparation staff. And it wasn't the type of cleaning that could be done by normal ambulance paramedics or staff. And so, the contractors responsible for that cleaning struggled to cope with the amount of cases that we were having to put up with. And we had to very quickly look to see how we could massively increase our fleet. Now, in the UK, ambulances are purpose-built vehicles, very similar to Australia. They're based around generally a Mercedes-type vehicle, but then have a dedicated box. So it's not the type of vehicle you can just go and resource from somewhere. And we actually had to go and work with other ambulance providers and local systems as well to see about getting mutual aid from across the surrounding areas of London and across the country. Because what we find is London became the epicenter for coronavirus in the UK very quickly. We were probably a month and a half to 2 months ahead of everybody else in the country with regards to the spread of coronavirus. We saw roughly, in the end, we had over 6,500 patients in hospitals across London with coronavirus. Over 200 deaths in London from coronavirus, and very sadly that included some of our staff as well from London Ambulance Service, who we did lose a number of staff to coronavirus during the event, and obviously that's tragic for everybody's concerned. The UK saw roughly 300,000 cases of coronavirus and 45,000 deaths, and it was a massive impact on us organisationally. It was a massive impact psychologically for staff. Staff obviously became very apprehensive. We had a lot of staff who were worried about going home to see their families, and in the end we ended up taking over hotels across London so that we could actually accommodate staff to stop them from having to go home if they had any concerns, or if they had members of their family that were particularly at risk, or shielding, so that we didn't increase any exposure to those vulnerable people by staff going home. We had some significant issues with the amount of PPE that we were going through, and the UK nationally had a problem with PPE stores. And what that resulted in was one of the downsides of how the NHS responded to coronavirus was that the rules with regards to PPE changed very, very frequently as to what types of PPE were necessary for staff to wear. And sometimes that changed on a daily basis, and sometimes multiple times per day. We would see new guidelines coming out from the centre with regards to what PPE was necessary for what types of patient, what types of cleaning was necessary for what type of patient. And the truth behind that was, where there was frequent changes in the guidelines coming out from the centre, it caused some staff to have doubts about the information that we're being provided with and on the efficacy of the PPE that was being provided, because what they saw was suddenly the standard of PPE necessary for dealing with patients was being reduced. So we started off with everybody having to wear FFP3 PPE masks at the start of the event. through to it was okay then for staff to wear surgical masks. And that, although there was evidence and good theory behind that, but obviously because staff were concerned at the time as well, and rightly so, because a lot of the patients that they were going to were highly infectious, it started to bring some doubts from the workforce with regards to whether there was just actually changes in PPE being issued just because of the shortages, as opposed to based around science around the actual spread of the disease. Because a lot of the time we were, for want of better terminology, we were winging it a little bit. Nobody knew what coronavirus was. Nobody knew really how it was going to spread. Nobody knew how it was going to act so quickly. And so the guidelines and the evidence did change on a daily basis, just purely as people became more aware of the type of disease spread. But some of the things that we did to cope with the demand is we very quickly went into partnership. As you probably know, the UK went into lockdown, and a lot of companies has laid off their workforces because of the risks of people staying within the workforce. And so we ran a voluntary campaign to get volunteers to come and join the ambulance service, not in frontline clinical roles, but to provide a lot of support. And as I said, the vehicle equipment systems and the vehicle cleaning systems needed significant workforce increases. And lots of people came and volunteered for us and started to work for the ambulance service for free of charge, because they'd been furloughed by their normal employer. And so they came and worked for us instead, because a lot of people wanted to give back to the community. We worked with the local fire brigade, the London Fire Brigade, and we saw 300 firefighters come and join us. We did lots of just-in-time training. We were very fortunate, but because a lot of the public events were closed, places like Wembley Stadium, which is the national football stadium for the UK in London, they were able to actually accommodate training for us, and so we could use the whole of Wembley to run significant large-scale training courses, so that we could take people from a fire brigade background and familiarise them with how to work in ambulances. Again, they were all already emergency driver trained, and it was just about having to give them familiarisation for, instead of using an 8-ton vehicle to drive through London, how to use the 3-ton vehicle, and how it responds differently, and how they could assist the staff, the paramedics. So we saw significant changes in our workforce. We doubled our workforce numbers overnight. At the peak of COVID, we had over 1,000 members of staff who were off work for various reasons, either that they were in shielding and so couldn't come to work because they were vulnerable, or they had COVID itself. And so we quickly increased our workforce, and we also had to quickly see about changing how we telephone triaged the calls, because our call volume doubled. And in reality was that the normal telephone triage system that we had didn't cope well with the pandemic environment. Although there was already a pandemic system available for that telephone triage system, it hadn't really been tested, and it hadn't been tested to the volume of the calls that we had. So we very quickly had to change how we telephone triaged patients, and what we also did was we set up a specific COVID call centre that, once it was quickly identified that the caller to the 999 system, which is the same as the 111 system in Australia, once those callers came through and identified that they had COVID type symptoms, we didn't use our normal type of response. We sent them through to a secondary triage call system so that we could put the caller through a more detailed assessment, because what we couldn't do is just keep sending ambulances to everybody, because we just didn't have sufficient vehicles. What we did to set up the staffing within that call centre, we took on all the third-year paramedic students to staff that call centre, because all the universities had shut down again because of COVID. And so because of all the universities shutting down, we had access to, obviously, the people who were paramedic students coming towards the end of their training programme, that we could then, who came and volunteered to work for LAS, and we put them in a dedicated call centre, where they were supported by more senior clinicians, so that as the calls came through, they were able to put the callers through a more detailed telephone triage process to decide if the patient needed a response or not. So we significantly increased the amount of people that we left at home, and we didn't have any adverse events as a result of that. So we had no patients suffer harm as a result of that, of the changes in the call system. And we saw in overall, although we seem to be a little bit slow in obviously being able to respond to start with, just because of the sudden increase in volumes, we've eventually got to the stage where we'd almost doubled our workforce. We doubled the amount of ambulances that we'd sent, and we actually got to a point where normal call volume reduced, and so all the calls that we were dealing with were COVID related. And for the first time in probably most ambulance staff's career in London Ambulance Service, at times there was actually more ambulances than calls. And what we're currently seeing at the moment is a very similar sort of profile. We've maintained our staffing levels at a higher level. We continue to keep London Fire Brigade partnering with us so that we can increase our level of response. Because what we're doing at the moment is we're basically prepping for a second wave. There is an anticipation that once lockdown starts to ease, as it's starting to do now, and as the communities start to move around more freely, we are anticipating that we're going to go back to having large areas or large activity levels with regards to COVID, unfortunately. Part of that response for us was that we shut down some of our infrastructure. London Ambulance Service normally operates out of 76 ambulance stations, and we found that we couldn't cope with that from a point of view of cleaning, stocking and welfare of staff. So we shut that down to roughly 40 sites. So we've got a lot more staff operating out of a lesser number of sites. But what we found was it meant that every member of staff got exposure to a team manager on a daily basis. They were able to receive briefings as opposed to just emails, and they were able to actually have a face-to-face contact to support, because the level of anxiety from staff was high, and rightly so. And so pretty much that was how we responded from an ambulance service point of view. So I don't know if anybody's got any specific questions that they would like us to go through.
Thanks, Justin here. Thanks, Kevin. That was a great overview. And obviously a lot of things happen in a very short time. We do have some questions. So Terry's got a couple around the mental health components. So his first component of the question is, how does the monitoring of staff mental health and wellbeing manifest itself throughout your organisational structure? It's a bit of a curly one.
Yeah, okay, and that's a very good question. So we have a dedicated welfare unit, and what we did at the time for COVID is we increased that to a 24/7 contact centre as well. So there's lots of welfare requirements. Mental health obviously just being one part of the welfare system that we have, and so there was lots of welfare issues with regards to accommodation. Sorting out people's laundry, sorting out people's transport, because the transport system reduced in the UK. And obviously as well, because of the levels of anxiety, what we tried, by reducing the amount of stations that we had, what we could do is we could put in a higher level of support to each of those sites. Generally, if we'd maintained 76 sites, we couldn't have had that level of face-to-face support because we just wouldn't have had the management team. Because again, the management team, like everybody else, were impacted by COVID. We had a number of managers that were having to shield or not be able to work had to work from home. And we did put a 24/7 full incident management system in place. So we increased welfare from a point of view of obviously the normal telephone support systems, but we also provided improved welfare and mental health by increasing the numbers of managers that are on station, so that staff could at least have a point of contact and actually could sit and talk to people if they had any concerns. Because one of the downsides of ambulance work is normally the crews don't get a lot of time to debrief. You know, they're generally busy. Most ambulance crews in the LAS will start work and will be out 10 minutes into starting a shift, and they won't get back again to the crew room to the end of the shift. One of the benefits of the coronavirus is because we consolidated, because we'd increased the staff numbers significantly, actually the amount of jobs per shift went down. So the staff had more downtime from the point of view of being able to self-debrief, talk to their colleagues and get support from the people that surrounded them.
Thanks, Kevin. There's a second part here that you might be able to answer. So did you have any metrics that you measured in terms of the welfare and monitoring welfare?
Just purely from the point of view of numbers of staff, so we had lots of measuring with regards to numbers of staff that weren't at work, numbers of staff that were either at work, but actually in accommodation being provided by the organisation, or numbers of people that were shielding, etc. So we had lots of metrics about the ability for people to come to work, but there was no specific metric we used with regards to how you assess somebody's mental health or well-being. Because, and to be quite honest, if that's the type of metrics that anybody could share with us, we would be more than happy to receive any sort of guidance on those types of things. Everyone's
on notice for that. Thanks, Kevin. So Deb's got a question about, she's gone, mentioned quite a bit about the great positives you've done to double the workforce and fleet and so forth. She's asking whether there was a plan behind that, or was that something that was more built as you went?
What we experienced absolutely made, and I'm being quite candid here, most of our planning wasn't able to cope with what we experienced from a pandemic perspective, because most people's plans were paper plans, and although everybody would have tested things on a desktop, no desktop, I've been in the job 28 years, and there's no desktop I'd ever actually experienced or gone through that prepared me for the coronavirus response requirements. So most of our planning, in all honesty, went out the window. And a lot of it did become reactive, because it is very difficult to try and articulate the scale of the incident that we had to respond to from an ambulance service point of view. So anything that we've done historically almost went out the window. We were quite lucky from the point of view of that, obviously, because suddenly most of the workforce is locked down or has been laid off or put into furlough. We suddenly we were able to go into partnership with organisations like the Automobile Association, very, very similar to the RAA. So because suddenly nobody was driving, they weren't getting that level of activity, so we could partner with them, and so they became we had dedicated mobile fleet capacity on all the ambulance stations to keep the fleet working. We suddenly had access to a significant workforce because everybody had been furloughed from their normal job. So in one hand, some of it was pretty much not making it up as we went along, because we did have a plan, but we were having to react very quickly to things almost on a daily basis. The good thing about that was there was sudden changes being enacted by government that meant we had extra staff, we had other extra organisations we could partner with, and it actually meant in the end our actual level of response was very, very safe, and our ability to respond outstrip demand, which was good.
I've got a question. Just you mentioned the secondary triage that was put in place specifically for COVID. Can you talk a little about the solutions that you were able to use from the secondary triage to prevent ambulance attendance?
Yeah. So the UK has two primary telephone triage tools. One of the tools that we use is very similar to a system that's used across most of Australia, which is the medical priority dispatching system. And that's a system where obviously anybody who phones 999 gets put through a set of predetermined questions. They have a specific card set within that system that allows to be enacted once there was a pandemic. And that's because one of the downsides with telephone triage is that by its very nature, it's risk averse. And also by its very nature, it assumes everybody is sick. And obviously a lot of the calls that we started to get in LAS weren't actually people who were sick. There were people who were very, very worried about what was happening. And so they wouldn't necessarily have any signs or symptoms of illness, but they needed a phone number to call just to get almost reassurance. And so we operate two numbers within LAS. One's 999, which is very similar to your 111. So your 000, and then we have a 111 system, which is very similar to your Health Direct system. So that's another point of contact staffed by clinicians such as nurses, physiotherapists, GPs, who would take calls. So we enacted the MPDS pandemic response. We also put in our own call filters as well, because that was a national type of a tool, and it was enacted across the whole of the UK. London was seeing levels of activity that were totally outside of the levels that had been seen by anybody else. And so although it was okay to enact a national tool, we still had then to make some local adjustments to that so that we could more correctly filter some of the calls that were about the worried well as opposed to the sick patients.
Thanks, Kevin. We've got a question from Dr. Megan Dobby, who happens to be from AV. And she's asking about the team manager welfare support. Was there any particular activities that the team managers found that they needed to use for staff welfare? She's reporting that perhaps more locally, we've got people that are getting fatigued, even though they haven't been through the experiences that London have been through yet.
Yeah, no, so our normal processes got stopped, and I need to say that. So we stopped managing sickness, and we stopped trying to manage people from the point of view of we have an attendance process. That is, if somebody is not at work, we put them through a various level of support systems to assist them to return to work. But sometimes it can be seen as a punitive system, and people get worried about going sick and those different types of things. So we basically, from a purely local point of view, the team management became about support, welfare, and actually just looking after your colleagues and your friends. There was no attempt to manage sickness from the point of view of how many times has a person been off. And we're only monitoring people's sickness from the point of view of welfare, to making sure that we were supporting people, that they were getting at least weekly phone calls for anybody who was in 12-week shielding. And so that the local management team became more about a point of contact, a friendly face, and also somebody who could be a point of knowledge that the staff could refer to because of the frequent changes in the policies and the procedures. We went to having face-to-face briefings for crews as they started work, because since they finished work yesterday, there might have been 7 changes to the way that we had to act, the type of PP that we had to use, or the types of processes that we had to follow for patients. Because not only were there enacting changes, but each hospital was setting up its own processes for how they would manage COVID patients as well. And so initially that was about the hospitals would manage a COVID patient coming in by ambulance by leaving the patient in the back of an ambulance in the car park. Obviously that then was worrying for the crews, because they were suddenly set there for 2 or 3 hours with a COVID positive patient in what is a glorified confined box. And obviously that's very worrying for the staff as well. So most of our issues were about, it wasn't so much fatigue, to be quite honest. It was more a cumulative type of stress, because they weren't doing lots of calls per se, but each call meant they were working in quite significant PPE. Each case was quite a protracted case because the amount of time they're having to wait with the patient and then wait for cleaning the vehicles, etc. And so it was, we didn't have anybody really complaining of fatigue. It was probably more about people's concern about their ability, the likelihood that they were going to catch COVID, or more importantly, the likelihood that they could take COVID home to their friends and family. And so the local CTMs, or the clinical team managers, really became a point of contact for staff to debrief and staff to offload. But the big key for us was making sure that we had 24/7 face-to-face support at every location.
Thanks, Kevin. That answers a couple of questions that have come up already, so thank you for that. Slightly different tack here from, I think, some of our emergency services colleagues. Interested in, were you able to keep politics out of the response and your activities?
Depends if you want an honest answer or not. So I don't think anybody can ever keep politics out of a public sector organisation, in all honesty, because we are a political organisation, and our health system is very political from the point of view of how it is used by politicians. But the politics between the services was non-existent. In fairness, it was, we asked for assistance from people from the LFB, the London Fire Brigade, and they were more than happy to provide us with assistance. We had very good cooperation from all unions involved in this, and obviously we are a unionised organisation, and obviously so is the Fire Brigade. And what we would normally have as the petty bickering, for want of better terminology, just didn't happen during COVID. Nobody tried to make any political gains as a result of how we were having to respond to COVID. Because I think, in fairness, there's just a generalised understanding that this was something that nobody had ever dealt with before, and nobody had any experience of this, or the scale and the levels of patient requirement. And so it would have been pointless to try and get political point scoring out of our levels of response. So organisationally and from a union point of view, it worked really well.
Thanks, Kevin. I think we all appreciate your very candid approach today and learning from your experiences. Just to wrap up this section of the teleconference today, I'm wondering if you can. I'm sure it'll be hard, but if you had to pick one key thing that went well and you'd do again, and one thing that perhaps didn't go so well and you would recommend us avoid, what would they be?
If I can start with probably the not so well is the frequent changes to how we were having to respond, or the PPE requirements. If I was to look at that again, and although we were being obviously advised very heavily from the centre, if I was to do that again, I would not allow the frequency of the changes to occur, purely because it took away some of the confidence from people about the efficacy of the decision-making process. Because, changing the type of PPE twice per shift or 3 times in a shift, obviously people start to get concerns about why those decisions are being made. And there was lots of doubts about whether it was just about availability of PPE as opposed to how effective that PPE was for the situations that patients find themselves in with patients. So if I would put everybody, from a fatigue point of view, I would say that people got more fatigued by change than anything else. Everybody was just change tired. Because it was just happening so often. So if I could control how frequently we put changes in, that's what I would do. Reflecting on things, I would slow down the amount of change, even if it meant not using the most up-to-date government guidance, purely because it meant that we could just wait at least 24 hours before we asked staff to start to think of something new again. With regards to what went well, what I certainly hope is that obviously what happened is a lot of the patient behaviour changed during the coronavirus. A lot of people stopped going to hospital because they were worried about actually going to hospital and catching coronavirus. And we have an NHS system which is free at the point of care. And obviously unfortunately that does mean that a lot of people will go to a hospital or ask for an ambulance to go to a hospital as opposed to go through their primary care provider such as a GP. And it puts a lot of strain on our system from the emergency services point of view. A lot of that traffic and a lot of those patients who would normally contact us for what we would normally as healthcare professionals think would be slightly frivolous stopped. And our secondary telephone triage system that we put in place for anybody who did continue to phone filtered a lot of those calls out. So what I'd like to see is a maintenance of those types of systems where roughly 10% of our activity is actually life-threatening. The other 90% is variable amongst really doesn't need an ambulance, but the person doesn't know where else to go. And I would hope that the changes that we brought in to respond to coronavirus can actually assist with that post-pandemic, so that we can actually reduce the normal everyday activity levels of the workforce and to maintain the amount of downtime that they can get from a welfare perspective.
Great, thanks, Kevin. And even though we haven't been through the same experience, I think we've noticed similar things in Victoria, that our workload has gone down. Unfortunately, what we are seeing is we're not seeing the chest pains and the shortness of breath patients. Yeah. The high acuity patients are not calling as well. So it's a careful message, isn't it?
It is, and that's exactly what happened with us as well. It wasn't just the people who were worried well stopped phoning us. We had a massive reduction in chest pains. The breathing difficulties went up significantly, purely because of a side effect of COVID, obviously being breathing difficulties. But it was almost like people stopped having CVAs and people stopped having MIs, or if they were having them, we don't actually know where those patients were going because they weren't contacting the health system. And it wasn't just ambulances who stopped seeing them. The hospitals stopped seeing those large numbers of patients come through as well. So we're yet to find out where those patient cohorts actually went to.
Mm. Well, Kevin, again, thank you very much for your candour and your experience. And I'm sure everyone on the teleconference today appreciates your insights. Back to you, Susan.
Thank you, Kevin. I've just got one question that I wanted to ask you. A lot of people here, and obviously the same in the UK, are working from home. How are you managing privacy issues? With data collection and things like that.
Yeah, so to work from home, so there's a lot of people not working from home, there's a lot of people at home. And I think that's probably a difference, to be quite honest. People who are working from home over here, we can only we have to have work computers that can go through a secure connection, and we don't circulate paperwork or patient report forms, etc. electronically. So there's only certain things that you can access from whilst working from home, and any way of getting onto the online systems means that they're very secure connections. So that, for instance, I can access patient records from at home on my computer, but again, I have to do that in an environment where nobody else from within my household could view those. My wife's in the ambulance service as well, but even we work on the rules that if you're not directly involved in that patient care pathway or process, you have no need to see that data. So even though in my household we're all in the healthcare profession, only I can review the documentation that's relevant to me, only she can review the documentation that's relevant to her. And it's about professionalism. Nobody's going to sit down.
Okay. All right, thank you very much, Kevin. I'm going to mute you now, and I'm going to introduce somebody who might be coming up on your screen as Philippa Keir, but I can assure you it's Frank Biggin. And Frank is a paramedic who is currently working at the Waterloo ambulance station in central London. He previously worked as an engineer for government, and he served in the Royal Navy. And in the ambulance service, he started as a technician, and he's a fairly recently qualified paramedic. So he's been right in the heart of it. And we just want you, Frank, to tell us, what was that experience like for you on the ground as a paramedic?
Hello, hi. Yeah, I think like Kevin was saying, initially it was very, very busy. I think the general sort of levels of anxiety, people that sort of unknown of what Wuhan and COVID-19 was. And for us on the ground, we were also unsure, so we were in the same boat as the public, information-wise, but we had to come to work to, help people and attend calls. And initially, like Kevin said, the calls were off the chart, 8,000 calls. We were getting constant updates about the change in PPE. So members of staff were quite anxious. But as time progressed through the pandemic, I think people were happier with the levels of PPE and what we were wearing. It was quite tiring at the start, having to dress in full PPE for most cases, and the dispatch system would give you a warning if it was COVID likely. So we would get a heads up, but we would be attending patients initially who had dry coughs, chest infections, and they believed that they possibly had COVID, and there was no sort of testing in place. So it was about seeing who was very unwell and who just had, coughs, colds, and trying to distinguish between the two. As I said, it was very hot, tiring, attending very sick patients. There was lots and lots of jobs. We would have to deep clean the ambulances if any patients were transferred. Lots of changes in hospital protocols. So they'd have red zones and green zones for possible infections and non-infections, and that changed quite regularly. So the morning briefings from team leaders were really, really important. We're in an amazing point that if we hadn't been in for a few days, there'd be such a huge amount of changes that we could sit down, have 20 minutes where we could all sit down, discuss what pathways had been changed, what the latest PPE was, so it would give us a better understanding of what we were going out to that morning. And after the initial huge amount of calls, the LAS had more members of staff to triage. The call rate of the calls that we were attending actually went down as we were working with our LFB colleagues and volunteers. There were actually more ambulances to attend the calls. So we actually went through a period where we were attending maybe 2 to 3 calls a day, but we would find that the patients were actually triaged, and they were actually very sick patients. So we were attending a fewer amount of calls, but the patients were a lot sicker, and lots of increasing COVID calls, people with all the sort of symptoms, shortness of breath, and they'd have oxygen saturations in the 60s and 70s. I think one of the hardest things for myself was knowing that these people were very sick and knowing that we had to take them into hospital, but family weren't allowed to attend to be with the patient, which was really hard to try and, knowing that these people are very, very sick and their family weren't allowed to attend. So that was quite, physically and emotionally, was quite hard for myself and for other members of staff. So, yeah.
Can I ask you a question about that? So given the scale of the exposure that you had and the exposure to that sort of grief, how do you think people on the ground dealt with that? Not to mention the grief of losing their own colleagues.
I think initially it was very hard going. I think there were lots of high levels of stress and anxiety, but I think generally in the public there was high levels of stress and anxiety. So it was only because we were doing this job that it might have been slightly greater, but there was lots of nurses. There was the Save the NHS campaign, which lifted people's spirits. And I think the dealing of the stresses and the strains was really just being together as an organisation, talking to colleagues, and really like debriefings, any really sort of stressful jobs, you were able to talk. And to be honest, I think that's probably the greatest thing, that everyone sticks together and is able to talk about how they're feeling, and be able to cope with it and say, if I'm not okay, and discuss it with somebody.
So what do you think was the single most effective strategy that LAS put in place for staff welfare?
I think one of the major concerns was that people would be coming to work. There's a chance that they could become infected. There was all things at the time about it staying on clothing and stuff like that. So I think people were concerned about taking or bringing the virus home to their families. And I think one of the most important things was people were given the opportunity to be able to stay in hotels, which would negate that if there was any person at home that was vulnerable. And I think that gave people a lot of peace of mind. So, yeah.
And so we heard Frank talk about management contact, but from your experience on the ground, how did management contact compare with before COVID?
I think there was a greater local level of contact. So a lot of it was done via team leaders, at briefings and support. There was management level was daily Facebook or LIA, it's a page, so they would have question and answer sessions via video chat, and basically answer people's concerns, any problems, and it was a good tool because people were able to get information when they needed it. It was daily and helped a lot.
We've lost you there, Susan. In the meantime, so thank you for sharing, Frank, your personal experiences. Often what we've found is that after the emergency, when the pressure's off, people tend to reflect, and without wanting to put you on the spot too much, what's your experience been sort of post that first wave?
I think a sense of relief, to be honest. At the moment, we've gone through the hardest phase, physically and mentally. The LS has managed to put things in place to be able to deal with it at its peak, so to speak. And I think people are more confident in being able to attend these jobs. The PPE is exactly what it should be, which gives people a lot of confidence. There's like COVID testing, antibody testing. So there's everything in place if people have got concerns, that they're able to allay them concerns. So yeah, I think it's been effective now, later on, that there's all these things in place that can make us more confident to do our job.
Justin seems to have frozen, so I'll ask you a question. Do you think the ability to talk about how you're feeling, you know, in this COVID environment, will help post-pandemic in terms of paramedics talking about their mental health and well-being?
Yeah, definitely. I don't think that in any way, shape or form it's good to internalise all the anguish and the things that you're dealing with them alone. You know, it's obviously easier for some people to discuss how they're feeling. And I think that's where when you've got a good crewmate, you're working with someone for several years, you can discuss, you know, how you're feeling about certain jobs, and basically, if you have got any issues, there's lots of support networks where we can speak to welfare, and they can pass us on to people to discuss how we're feeling, talk about jobs, how they've made us feel. And yeah, just to not get to that heightened levels of anxiety and ongoing sort of mental health. And
Justin, do you have any more questions?
Yes, thanks, Frank. So thank you for that. So we heard that London Fire Brigade were involved as well, and you just mentioned, you know, working with a good partner was important, and we're certainly looking at those sorts of arrangements here in Victoria as well, working with other agencies should we need to split crews and you know, increase our capacity. Did it work as well working alongside other agencies? Did you feel the same support, or is there additional requirements there?
No, I think it was fantastic. So the LFB were obviously trained in CPR, and they've obviously got a host of experience from working as firefighters. So I think it was a learning curve for them and a learning curve for us. So the LAS would be an attendant. They would do the paperwork and do the medical aspect side of it. And the LFB would do anything else, driving, lifting, support, and they would then in turn learn as we went on, and you know, some of them would ask questions. They'd want to know how they could distinguish different signs and symptoms. So it was really, really good sort of interagency cooperation.
Excellent, and likely to continue into the future, I presume, as a result?
I assume at some level, but I'm sure Kevin would be able to give you more information on that.
So it sounds as though you felt well supported. Kevin mentioned the frequency of change, and we saw that as well. So should there be, you know, a resurgence as happens in other pandemic environments? What are your feelings, you know, moving into the future?
I think moving into the future, I think we're a lot more well prepared. As I say, like Kevin said earlier, no one had the expectation that it was going to be this severe, and the amount of pressure placed on the ambulance service, knowing like London's busy already call-wise, and then to have your calls double and be busier most days on the New Year's Eve is, you know, significant. But I think future, PPE, everybody's happy with it. It's, you know, the correct level, cleaning of vehicles, everything's in place. So I think if it does, and there is a resurgence, I think we're in a really, really good position as a London Ambulance Service to be able to deal with it.
Tremendous. I might just focus on a couple of clinical questions just whilst we're waiting for the audience to put in some other questions. Hint to the audience, put in some questions. You mentioned that you had some quite unwell people with very low oxygen saturation. Did you find you needed to modify your clinical practice at all, or was it more routine shortness of breath with infectious overlay?
So initially you'd go to people and there'd be various signs and symptoms, but the really sick patients, they'd have low oxygen saturations. You'd end up giving 15 litres of O2, sometimes nebulisation, but significantly you would still, even given 15 litres of O2, they still have saturations 80%, and it would just be a case of getting them in quickly and monitoring them en route and getting them where they could be put on a ventilator.
And how did you find operating in the PPE? So, you know, we've all been through that, even locally in our situation. But how did you find such a long period in PPE and undertaking those activities? So
initially, the very first cases, we would wear full PPE, Tyvek suits, full-on face masks, and we'd be in them for prolonged periods of time. So it could be we'd take patients to testing centres, and we could be in the suits for 2 hours. And then as it's progressed, and there's been more appropriate PPE, we have spent less time in them. The only time at the moment where we'll wear them for prolonged periods of time is when attending a cardiac arrest due to AGPs. And yeah, then it become quite uncomfortable, hot, especially on sunny days and, you know, properties with heating on. It can become, need to hydrate a lot.
That's certainly been one of the findings, hasn't it? That the PPE dehydrates a lot more than we perhaps understood.
Yeah, significantly, yeah.
All right, Susan, back to you. Oh, we've lost you, Susan.
Yeah, we were going to show a video now from the wellbeing team at the London Ambulance Service, but because of technology issues, what I'm going to do is put a link to that video in our newsletter that we will put out tomorrow. So I think that's a better way of showing it than sharing the screen here, because we've been having a few problems. So I think that's probably about it, unless anybody, well, there's a couple of other questions there, Justin, I can see. Let me see. A question for you, Frank. Apart from the information side of the morning briefings, what other aspects of personal support was the most beneficial for you personally?
Personally, I think sort of management-wise, team leaders, if you did have any concerns, they would talk to you. They would be able to stand you down for periods where you were able to discuss it. I think also because we, after the initial first wave, we had a lot more downtime because, you know, lesser sort of amount of calls. We were able to speak to our colleagues and discuss what had been going on, our concerns. So I think that support network with the team leaders, if there were any significant, you know, concerns, that you were able to discuss them. Just a sort of open communication and just being able to access support when needed.
It's the phrase of 2020, isn't it? You're on mute. So what about clinical protocol changes? We've heard Kevin talking about so many changes. How was that information actually disseminated to the workforce?
So initially, we would get email updates, which would be a COVID protocol. It would have all the clinical updates. It would have any changes of clinical pathways, and the morning team meetings, you'd be able to discuss, you know, why was this put in place? Why was it changed? And I think a lot of it was around discussion of what AGPs were, and it's slowly been refined. So yeah, I think it was just being able to discuss, and it's sent out in email and given paper copies if need be.
Okay, look, I think we might draw it to a close there and say thank you so much to Frank, to Kevin and to Justin for being part of this session. ESF will put out an impact newsletter tomorrow, and in that newsletter we will have a link to the wellbeing team at the London Ambulance Service, and they're going to be answering some questions that the ESF Learning Network put to them earlier. So if you don't automatically get the ESF impact, go onto the ESF website and there's an opportunity to subscribe to that. I'm getting some great feedback from people saying thank you so much, really interesting to hear about all your perspectives. So thank you for getting up early, and thank you for joining with us. I do have one question for Kevin at the end that I just thought of. And I was discussing this with someone today, Kevin. Do you think the changes that you made in the way you do things happened in a way that, you know, maybe 6 months ago, if somebody had suggested you do it, people would have said, oh no, that's not possible. But just because of the environment, you've been able to make changes and people have been more willing to try new ways of doing things.
Absolutely. I think we've been able to implement change very quickly. We are a bureaucracy, and sometimes making changes for better takes a long time, and we were able to circumvent some of those requirements. However, also as well, some of the changes we made outside of COVID wouldn't be appropriate because they were based around the levels of risk being experienced at the time. So we are having to go back through and look at all the changes we made just to do risk assessments on those changes and those decisions to make sure that the things that we did implement were appropriate for the public requirement as it is now, as opposed to what we were having to respond to during the peak of COVID. So,
what do you think was the biggest lesson for the NHS that that the sector will take out of this?
For the wider NHS, I honestly have got to say my expertise is in ambulance, so I don't. Somebody from an acute setting such as a hospital might have a different view on me, but I would suppose and I would say probably having a background in emergency preparedness as well. It's about testing your plans, and so although I would say test and retest your plans, COVID was something that we could never have anticipated. So I don't think our planning would have ever have actually dealt with this. Or if we'd have tried to plan and say with the volumes that we'd have got and the activity we'd have got, nobody would have believed us historically that was ever going to be a requirement. And so if the only thing I would say is test your plans, review your plans and test your plans again. And there is no such thing as a silly suggestion when we're dealing with things like COVID, because it very nearly brought the NHS to its knees because of the hundreds of patients per day that were on high level interventions and ventilations. It was massive, and it nearly crippled the health system here. So my only advice would be test everything that you've ever thought and question again about it, whether or not you're actually going to have the ability to cope.
And it might be too early for this, but has there been any discussion about going back to the workforce to evaluate and get feedback from them about their experience during this time?
Yes, so that obviously, like every organisation, the workforce is our most valuable asset. And obviously when we're looking at things that are impacting on the workforce as well, their ability to come to work, it's vital that we maintain their confidence. What we're currently doing is we're still in a COVID response phase. So we are still planning for the next wave of COVID. And so we aren't evaluating everything yet, but we've used our normal emergency preparedness and response arrangements for an after action review. And the whole organisation will be involved in that after action review. So we'll set up things such as survey monkeys, and we'll have face-to-face meetings, because it is the first time, and hopefully it'll be the last time we ever have to do a lot of these things. But we've now had an experience. We need to learn from that experience. We need to evaluate everything we do as a result of that experience, and we need to make sure that the workforce participate in that. Because if they don't believe that they've been heard, then it is going to significantly hamper any of the future planning that we might have.
Well, thank you very much to Justin, Kevin and Frank again, and to Philippa behind the scenes, who's been helping me enormously. And so go and enjoy a nice breakfast now, and I hope you have a good day. And Justin, have a good sleep. I know you've had a very big day. So thank you to everyone who tuned in, and look out for our ESF Impact tomorrow, where we will have that recording from the wellbeing people. And I'll say good night to everyone in Melbourne. Stay safe. Thank you. Thank you.